Okay, so today we have the second part of critical care mock session with the respiratory system.
Okay.
So first of all, we have the respiratory acidosis. So kindly read the scenario and then we will continue.
Okay, sir.
Okay, so can you tell me how carbon dioxide is transported in the blood?
Sir, carbon dioxide is transported in the blood in three ways: 70% in bicarbonate form, 20% in carboxyhemoglobin form, and 10% in the dissolved form in the blood.
Okay, so can you tell me about the equation that uses carbon dioxide and bicarbonate for its transport?
The H2O combines with the carbon dioxide with the help of an carbonic anhydrase enzyme to form H2CO3, which is broken down in the RBCs into H plus and HCO3. The H plus combines with the hemoglobin, and the bicarbonate goes out of the RBCs.
Okay, so what is chloride shift?
Um, the chloride shift is the influx of chlorides into the RBCs when the bicarbonate moves out.
Okay, so why in this case there will be no metabolic compensation?
The metabolic compensation occurs in the kidneys, which takes 3 days.
Okay, and why bicarbonate will be normal?
Um, Bicarbonate, because it shifts out of the plasma.
Okay, so if you don't know the answer, just skip it so that we can
Yeah,
come to it later on. Okay,
yeah,
this will be
okay,
your practice and it will be helpful in your exam as well.
okay. So
Okay, so what are the different types of respiratory failures?
there are two types of respiratory failure: type 1 and type 2. Can I explain, sir?
Yes.
In both the types, there will be decreased PO2, but in type 1 respiratory failure, the PCO2 will be normal, while in type 2 respiratory failure, the PCO2 will be high.
Okay, so how does morphine acts?
The morphine acts through the new receptors um, in the respiratory center.
Okay, so can you tell me where is the respiratory center located in our body
Mm, Pons.
and anywhere else?
Mm, um, Sorry, sir.
Okay. So can you tell me about the receptors which are responsible for respiration in our body?
The central chemoreceptors are responsible for
Yes. And what
the
is the
respiration.
role of these central chemoreceptors?
The central chemoreceptors are located in the brain. Upon stimulation by increased carbon dioxide, it causes a central acidosis, which stimulates the central chemoreceptors, leading to an increased respiratory rate. In increased respiratory rate, the patient will wash out the carbon dioxide.
Okay, so can you tell me about the peripheral receptors which are responsible for respiration, where they are located?
In the carotid region, sir. Um, the peripheral chemoreceptors are located in the carotid region. It
Okay.
senses any increase in the PCO2 or decrease in the PO2.
Okay, so what type of respiratory failure will be present in this scenario?
In morphine overdose, there will be type 2 respiratory failure.
And what is the response mechanism towards the hypercarbia?
Uh, Sir, in cases of increased CO2, there will be central acidosis, which leads to increased stimulation of the central chemoreceptors in the brain, leading to increased respiratory rate to wash out the carbon dioxide.
Okay, so where will you manage this patient?
Sir, I will manage the patient in the ITU.
Okay, so what will be your management plan?
So I will manage the patient according to the Secretion protocol, the A to E approach. So I will first check the airway of the patient, then the breathing and ventilation of the patient, and I will start with high flow oxygen. Then I will, if the patient's saturation is maintaining, if the patient requires any ventilatory support, I will discuss it with the anesthetist. And I will also check for the circulation of the patient. I will start with the, if there is no cannulas, I will insert two large IV bore cannulas and start fluids if there is hypertension. And also, I will, since the patient is having morphine overdose, I will give antidote naloxone.
What is the dose of naloxone?
No idea, sir. No idea.
Okay, so can you tell me about the criteria of admission in the ITU?
Uh, the patients with hypotension and the patients requiring emergency surgical managements and patients requiring any massive blood transfusions, pulmonary embolism cases. Mm,
Okay.
yes.
So can you tell me that how does morphine causes respiratory failure?
Morphine acts on the respiratory center, causing respiratory depression, the center depression. So there will be decreased respiratory rate. So the there will be carbon dioxide retention leading to hypercarbia.
Okay, so can you tell me about the side effects of morphine?
Mm, Sir, side effects can be divided systemically, so system-wise. So in the GIT, it can cause constipation. In the renal system, it can cause urinary retention. In the it can also lead to itching due to release of the histamine. Then in the central nervous system, it can cause drowsiness, headache, and vertigo.
Okay, so you answer very well in this respiratory acidosis, apart from just 2 to 3 things.
Okay.
So regarding the ITU admission criteria, so the patient who requires a mechanical ventilation,
Okay.
they must be shifted to ITU. And
Okay.
when there is a requirement of nurse to patient ratio of 1:1.
1:1.
Yes.
Okay, sir.
And when two or more systems of the patient are failing or the patient is going into multi-organ failure.
Okay. Two or more systems. Okay, sir.
Yeah.
Okay, sir. So, okay, sir.
Okay, that is the question that you missed. I guess rest were okay. Okay, so next we have the pulmonary embolism. Kindly read the scenario and then we will continue.
Mm. Yes, sir.
Okay, so depending upon the scenario, what will be your differential diagnosis?
Sir, pulmonary embolism. Um, then in the respiratory system, pulmonary embolism, chest infection, basal lobe atelectasis. In the GIT, abdominal sepsis, intra-abdominal hemorrhage, and the fluid overload since uh,
So why are you suspecting pulmonary embolism in this scenario?
uh, because the patient is a case of malignancy in a hypercoagulable state. Uh, so there could be tachycardia, tachypnea. The patient is having a heart rate of 110 and a respiratory rate of 24 with a decreased oxygen sats that is 90 percentage.
So how will you approach the patient?
Sir, I will manage the patient according to the Secretion criteria, Secretion protocol A to E approach. I will check the patient's airway if it is clear. Then I will also check for breathing and ventilation. I will start the patient with high flow oxygen through an NRBM, a non-rebreathable mask. And if there is no improvement, I will discuss with the anesthetist or the ITU registrar regarding intubation. And regarding circulation, I will check if the patient is not having a fluid overload. And if there is no cannulas, I will insert two large IV bore cannulas for resuscitation, fluid resuscitation. Then I will check for the improvement in the circulatory status of the patient with the help of a pulse rate, BP, capillary refill time, urine output, and mental status. Then, I will do some blood investigations also, which is ABG and RFTs. I will also do chest X-ray, ECG, and CTPA. CTPA after the RFT results are available. Yes.
Okay. So this ABGs are provided. So what will be your diagnosis on the basis of the values provided in this ABG?
pH is 7.49, which is alkalosis. Then bicarbonate is normal, PCO2 is less. So it is a case of respiratory alkalosis.
Okay. So why do you think the patient is having respiratory alkalosis?
Due to hyperventilation, the patient carbon dioxide washout occurs, leading to respiratory alkalosis.
Okay. So can you tell me about the mechanism of action of low molecular weight heparin?
The low molecular weight heparin exerts its antithrombotic activity by binding and accelerating the antithrombin 3, which leads to the activation of factor 10A and factor 2A, leading to decreased thrombin and prevention of clot formation.
Okay. So this ECG has been provided to you. Can you explain the findings?
ECG shows a sinus rhythm with tachycardia.
Okay. So what is the gold standard investigation for making your diagnosis of pulmonary
Uh,
embolism?
CTPA, sir.
Okay, this is the diagram of the CTPA. Can you interpret the findings?
The CTPA shows a thrombus in the pulmonary vasculature, which is suggestive of pulmonary embolism.
Okay, so can you tell me about the pathogenesis of clot formation?
Sir, initially there will be endothelial injury, which leads to stasis of blood and platelet activation and aggregation until there is clot formation, fibrin-led clot formation.
Okay, so regarding your differentials, always
Yes,
try to classify them. Okay, so the
okay.
first and foremost in this scenario will be the respiratory differentials. That
Yes,
includes
sir.
the pulmonary embolism, chest infection, and basal atelectasis because the patient is post-op and the patient is currently immobile. So basal
Okay.
atelectasis will also be one of your differentials.
Important differentials. Okay, sir.
And as it is an abdominal surgery, so you will be keeping abdominal sepsis and intra-abdominal hemorrhage as your differentials. And the
Okay,
last,
sir.
it could be because of fluid overload as well.
Okay, sir.
And one reason that you missed in the pulmonary embolism suspicion was the post-operative immobilization, which is one of the
Post-operative.
most
Yeah.
important one. Okay.
Okay, sir. Okay, sir.
And in the management or approach, also explain the exact management. Okay. For the patient being stable and non-massive, you will start with the low molecular weight heparin. And if there is
Okay.
a unstable patient and there is massive pulmonary embolism, then you will move
Uh,
toward the surgical embolectomy.
Surgical embolectomy.
Yes.
Then, in massive pulmonary embolism with the patient, if the patient is unstable, I will assess if the patient is having any bleeding risk or not. If the bleeding risk is low, then I will go ahead with surgical embolectomy followed by a full dose of TPA. If the bleeding risk is high, then I will go with surgical embolectomy or catheter directed embolectomy.
Yes.
Uh, Okay.
Yeah.
I will.
So I guess rest was pretty well. So next we have the scenario of SIADH. So kindly review the scenario and then we will start.
Yes, sir.
Okay, so what is your diagnosis in this scenario?
So this is a case of SIADH, which is secondary to lung cancer.
Okay, so can you tell me what is paraneoplastic syndrome?
Um, uh, Paraneoplastic syndrome occurs in cases of malignancy, especially small cell carcinomas. Uh, there could be an activity like hormonal secretion from the malignancy, and this can be present even in the GIT also. Mm, yes,
Yes.
goblet cell tumors,
Yes.
like
Okay,
that.
so can you tell me about the causes of SIADH syndrome?
Uh, Causes. Uh, Sir, yeah. So the causes can be due to meningitis or subarachnoid hemorrhage. Then it can also be due to cerebral abscess or atypical pneumonia. That it can also be due to hypothyroidism and like malignancy, like in this case, small cell cancer, then due to certain drugs.
Okay. So what investigations you will follow to reach your diagnosis in this scenario?
I will do both blood and urine investigations. So, in the blood investigation, I will check for the serum sodium levels, serum osmolality, and blood pressure. Then, in the urine, I will also check for serum cortisol in the blood to rule out Addison's disease. And in the urine, I will check for the urine osmolality and urine sodium levels. I will also check for TFTs, hypothyroidism.
Yeah. So can you tell me where is ADH released?
ADH is released from in the hypothalamus from the supraoptic and the paraventricular nucleus. Then it goes through the neuroepiphyseal tract to the posterior pituitary gland. Then, when stimulated, the ADH is secreted, which acts on the ADH receptors present in the mm, distal convoluted tubule and the collecting tubule, which leads to the activation of the aquaporin 2 channels. The aquaporin 2 channels moves from the cytoplasm to the apical membrane in the tubules, leading to water reabsorption from the collecting tubules, leading to water retention, but solutes will not be absorbed.
Okay, so can you tell me what is the half-life of ADH
15 to 20 minutes. So.
and what is the action of ADH?
The ADH acts on the ADH receptors present in the distal convoluted tubule and the collecting tubule in the in the nephrons. It leads to the absorption of water by activation of the aquaporin 2 channels. The aquaporin 2 channels in the cytoplasm moves towards the apical membrane of the tubules, leading to absorption of water, but solutes are not absorbed. So.
Okay, so can you tell me about the rate at which sodium is corrected?
Sodium should be corrected very slowly. Initially 0.5 to 1 millimoles per liter in per hour, or 6 to 12 millimoles per liter in first 24 hours to the maximum of 18 millimoles per liter in 48 hours.
And why we replace sodium very slowly?
Due to osmotic demyelination in the of the neurons. We have to replace sodium very slowly.
Okay, so can you briefly explain the management of SIADH?
Management. So we have to correct sodium very slowly, and we have to check if the patient is normovolemic, hypovolemic, or hypervolemic. Then we have to check for the ADH levels. Yes.
Yes, very well. You added a lot of information. That's very good. So we can restrict the fluid and we can add replacement of sodium depending upon its value. So normally it is 135 to 145. So if it is above 120, we can give normal saline to this patient at a very slow pace. But if
Okay,
it
sir.
is very much less, like less than 120, then we will be using the hypertonic saline to replace the
Hypertonic.
sodium.
Sir, less than how much, sir? 120.
120
Okay, sir.
millimoles per liter.
Okay.
And then we will try to identify the reason, as you said, that whether it is hypo, U, or hypervolemic, then we will reach the reason and try to resolve that.
Okay, sir.
And also add that I will manage according to the seek risk protocol. starting
sir.
with A to E approach. First of all, I will check for the level of sodium and its severity. And depending
Okay.
upon that, I will move with the fluid status and replace sodium.
Okay, sir.
So, like in this way, if there is such a scenario that you are not aware of, at least try to add the information that has been provided. Okay, so it's a critical care scenario, so you have to say it's secret. Okay, it's
Secret.
a
Okay, sir.
new trauma scenario,
Trauma.
then you have to say ATLS.
ATL.
Yes, so
Okay,
just
sir.
keep these things in mind so that you
Okay.
have a good practice of speaking these things.
Okay, sir.
One additional question which can be tested in this scenario is the different types of lung cancers.
Okay.
So there could be small cell lung cancer and non-small cell lung cancer. However, you can get the detail of this question from the pathology section because there is a complete scenario for this lung cancer. So you can add that information from there if you're asked in this scenario.
Okay, sir.
So any questions
Um,
regarding today's session?
yes, sir. Sir, in the other case, there was in the pulmonary embolism scenario,
Yes.
there was temperature of 38 degrees Celsius. So I was thinking if could be abdominal sepsis.
Sorry, what? Regarding abdominal sepsis?
The temperature is mildly raised now, so 38 degrees.
You will keep it because there was an abdominal procedure that was performed.
Okay, okay, sir.
That is
Okay,
why, because it was sigmoid colectomy. So it is
okay,
highly likely to get infected and there is an anastomotic leakage.
okay, sir.
Like it does not, definitely you will be putting it at a very lower place because the primary goal is to place the respiratory differentials
First,
on
okay,
the top. Like then you will
okay,
go towards the other secondary scenario differentials.
okay, sir.
Okay. Anything else?
That's all, sir.
Okay. Thank you very much.
Thank you, sir. Thank you very much.